And good evening, and thank you for joining a virtual community lecture brought to you by Providence. Our focus this evening is back and neck pain. I'm Tom Burton, physical therapist and executive director for orthopedic sports medicine and the Spine Clinical Institutes here in the South Division, covering most of California. Our guest speakers this evening are spine experts, Brar and Bowen Jang. Before we get started, though, I want to let everyone know that this is an hour-long presentation. I already saw that in the questions. And we will have plenty of time for questions at the end. Please use the Q&A box to type in any questions you have, and we'll do our best to get to each question at the end of the presentation. Please note that we are not able to answer personal medical questions, but certainly we'll answer general spine-related questions. If we're unable to answer your questions, please feel free to email to CA Lectures, LECTURES, at Providence, PROV as in Victor, IDENCE.org. And we'll get back to you at our earliest opportunity. Providence has 17 hospitals across the California area, and they're here to care for all your medical needs, especially when it comes to your back and neck pain. By bringing together expert physicians, such as this evening, experienced nurses, and highly skilled therapists, Providence provides complete back and spine care, from physical therapy and pain management to surgery. Our expert neurosurgeons and spine care teams can help you and restore function and improve your quality of life. You can feel confident knowing that Providence can care for both you and your family. Lastly, we want our attendees to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Now, it is my pleasure to be able to introduce to you Dr. Nikhraj. Dr. Nikhraj is a board-certified interventional pain management physician specializing in minimally invasive spinal procedures here at Providence. Dr. Brar completed his residency in physical medicine and rehabilitation at the prestigious Stanford University and an interventional pain management fellowship right across the water over at UCSF, their School of Medicine. With expertise in fluoroscopic guided minimally invasive procedures, he offers a range of treatments, including injections, radiofrequency ablation, neuromodulation, and pain-relieving medical device implantation. Dr. Brar collaborates closely with spine surgeons and physical therapists to develop comprehensive pain management plans for his patients in his free time. Dr. Brar loves watching the Los Angeles Lakers and definitely enjoys traveling the globe. Dr. Brar.
Thank you, Tom, for that wonderful introduction. And thanks for everyone for being here. Usually I don't like to talk too long. My wife gets mad, but now I get to actually talk, and I'm sure people will appreciate what I have to say. So I've been with Providence for the last 4 years. I provide spine care for patients from all walks of life. I do mostly interventions. I also do some administrative stuff, serving as medical directors for my medical group, as well as helping with our regional spine advisory council. Next slide. So interventional pain management, there are 3 levels of pain. There's pain, there's excruciating pain, and there's stepping on a Lego. Now, I don't know how many of you have kids or have had kids or grandkids, but when I step on a Lego, it's probably the worst thing that I can feel. So I don't think anything's going to be as bad as that. So we have got a solution for whatever you have. Next slide. So let's get into the facts. So pain is probably one of the costliest diseases, conditions in the United States. We spend about $500 billion a year, every year annually, on treating pain. That comes to about $2,000 per person in the United States. So if you think about that, think about how much you've spent on yourself doing anything. $2,000 is a lot of money. And not everybody has pain. So that means the subset of people that do have pain are actually spending a lot more than $2,000 yearly. Healthcare overall costs $261 to $300 billion annually, and there's a loss of productivity that's $297 to $336 billion. So that's how your $500 billion is split up, pretty much equally between the healthcare cost to treating pain and the loss of productivity associated with it. Next slide. So the incidence of chronic pain is actually more than diabetes, heart disease, stroke, and cancer combined. So just to kind of grasp that, you know, sometimes pain is something that's ignored. People don't always treat it. It's not going to be at the top of people's minds when you go in for your annual checkup. And, you know, the big ones that we're always focused on are the ones here mentioned, really heart disease, stroke, cancer, and diabetes. And more people suffer from this than suffer from all of those. I think it's just a stunning fact. Next slide. So when we get into common pain conditions, let's get into how the breakup is. So low back is the lion's share of pain. The most common pain condition is low back pain. Then next we have headache, neck pain, and facial pain. So when we take away facial pain and we talk about low back, neck, and even headaches, that actually encompasses the spine. So when we're talking about spinal pain, treating spinal conditions, we're really treating the most common pain conditions that people have. When we go through some more statistics, about 26 million Americans between 20 and 64 experience low back pain, okay? The number goes up as we get older. Or as one of my professors used to say, don't ever say old, just say advanced stage of youth. So as our youth advances in stage, we have more pain. Low back pain is the #1 cause of disability in the United States, and adults with low back pain often suffer increased incidence of physical and mental disability. So pain not only affects, you know, your physical ability to do things, it also affects you mentally. Next slide. So chronic pain patients, so 50% will feel they have little control over their pain. Okay, 60% experience breakthrough pain, which means pain that is breaking through on top of their chronic pain. And about 2/3 to 80% will say it affects their activities of daily living. So this isn't something to, you know, laugh about. I mean, this is really something that is really a problem, and is something that we need to treat. Next slide. So I always tell people when they come to see me, I'd like to give you a 50,000-foot view of how we're going to treat your pain. Okay, so the treatment algorithm I kind of break up into 4 different categories, and not necessarily in the order that's listed here, but generally in the order that's listed here. So there's medications. Okay, the good medications to treat back pain are going to be the anti-inflammatory, so your ibuprofen, your Aleve, and the other medications that are in that class, as well as Tylenol. Those medications actually have evidence of treating spinal pain, and if there's nerve pain associated with it, there's nerve pain medications as well. We often use that as a first-line treatment for people, and we usually combine the second category, which is modalities and therapies. That could include physical therapy, that could include chiropractic therapy, that could include acupuncture, that could include yoga. So we really want people to try to engage their body, engage their spine, engage their core muscles, and try to increase their mobility by strengthening the muscles around their spine, therefore supporting the spine a little bit better. And sometimes the body just needs to learn to move again if you're sedentary a lot, or needs to learn how to move a different way. And so we're hoping that the majority of the patients get better just with medications and modalities alone. Now, let's say you're in a situation where you've tried some medications, you've tried some therapies, and you still have back pain. That's when we get into sort of the 3rd and the 4th categories. And those happen to be interventions and surgeries. So I'm not going to touch on surgeries. That's going to be the next part of this talk, but I'm an interventional pain specialist and I do interventions. So that's what we're going to focus on today. So interventional therapy is really minimally invasive but targeted procedures to try to decrease pain. And the goal is the same goal as the medications and modalities, really keep you away from the big surgical interventions and try to get your body to sort of adapt to the pain that you have and keep you functional and going. Next slide. So the comprehensive approach pre-surgery would be really a combination of things. Let's say the medications and therapies didn't work and now you're going to see me and have an injection. That doesn't mean I want you to stop taking some of those medications that do help day to day, like an ibuprofen or a Tylenol. It also doesn't mean I want you to stop doing the exercises that you've learned for your physical therapist. If the physical therapist has taught you to engage your core and do those core exercises, doing those each and every day is going to be important for your back health. And it's going to actually, in the long run, help prevent a worse problem from happening. My interventions are just going to be designed to give you some pain relief and allow you to do those exercises that you might have been taught by your therapist. Next slide. So what is interventional? When is interventional pain management appropriate? It's appropriate for patients who are in chronic pain, who have failed more conservative therapies like medications, modalities, and therapies, and when their functionality and quality of life are reduced due to pain. Next slide. And what is interventional pain management? And like I alluded to earlier, it's the use of minimally invasive techniques, procedures, or even small surgical procedures that will reduce acute, chronic, or cancer-related pain conditions. And for the purposes of this talk, we're going to focus on those spinal conditions. It generally does not involve the use of prescription medication. That is something that you might have tried before you see an interventional specialist, or you may not want any medication at all, which is also fine. Next slide. So what do interventional pain management specialists treat? Well, we actually treat all these things. We'll treat joint pain, back pain, neck pain, facial pain, complex regional pain syndromes, abdominal pain, chronic pelvic pain, and we have interventions for all of these things. However, what we're going to focus on today is just the specific interventions for the spine. Next slide. So how do we treat these things? We do injections like epidural steroid injections, trigger point injections. We'll do nerve blocks where we block specific nerves that are producing a painful signal. We'll do something called a radiofrequency ablation, which is where we burn a nerve that is causing pain and therefore shut it off for an extended period of time. And what that really means is nerves will grow back. And so that's why you don't get a permanent, stop of pain with the nerve ablation. We can do something called neuromodulation, and this is where we implant minimally invasive devices either in the spine or along a nerve in the periphery that will actually sort of go in there and act like a light switch and shut off a painful nerve signal as it goes to your spine or brain so you don't feel the pain. And then we also have some minimally invasive procedures where we can do small little fusions. We can actually repair some vertebral compression fractures, and we can actually go in and decompress the spine by doing a mild procedure where we take a little bit of a ligament out. Anything beyond that, we leave to our surgical colleagues. Next slide. So how do we do these procedures? We don't just aim and hope that we get it. We use some imaging guidance. So this is a fluoroscope. It's basically an X-ray machine that allows us to, in real time, view our needle as it is going to a targeted site within your body so that we perform these procedures safely and accurately. Next slide. So now we're going to start getting into the diagnosis portions of the talk. So this is just meant to be a general overview of different conditions that can cause your pain, what these conditions might feel like to you, and some potential solutions to treat this pain. So next slide. Well, let me go back there. So this is facet joint arthritis. So what this means is that the joints that hold together your spine can become arthritic and inflamed, and these produce the typical backache. This pain can sometimes radiate to the butt. It can sometimes radiate out to the hips. It usually does not radiate to the lower extremities or the legs. And it's often really difficult to extend your back. So if you try to arch your back and you kind of have to grab it, that's really typical of facet joint pain. Next slide. So our solution to that could be a lumbar facet joint injection, where we actually stick a needle in to the joint itself and provide cortisone. That can typically produce several months of relief. Next slide. Or we can do a radiofrequency ablation. And what this means is that we actually burn the nerves that sit adjacent to those arthritic joints, and it will shut off the pain signal from those arthritic joints. And people can typically get 6 months up to 2 years of pain relief when we do this. People always ask me, why doesn't burning a nerve permanently stop the pain? And the reason is nerves grow back. They're kind of like weeds. You pull a weed, it grows back. Nerves are the same way. So it can often take that 6 month to 2 year time to grow back. And that's what gives you the time relief. And then you can do it again. Next slide. This is a disc herniation. The disc herniation is basically when the disc material that cushions between the vertebral bodies of your spine juts out to a place where it shouldn't be. So what I always like to tell my patients is think of a disc like a jelly-filled donut, okay? And these donuts are providing cushion between the bony parts of your vertebral bodies. Well, something can happen, and that disc or that donut, if you will, can be crushed, and that jelly material can come out and start to compress things within the spinal canal. And often it can compress a nerve, as is shown here on the top slide, or it can compress like the spinal cord, which is the central location right around here. And if it's compressing those things, that can cause pain in your back that can actually radiate down a leg or both legs. Next slide. So spinal stenosis is where this disc herniation or even the bony overgrowth in the back can actually decrease the space that the spinal canal has. So if we look at this part of the slide on the left, this is showing a cross section of your low back sagittally. And what you're looking at is you have a normal spinal cord where the yellow is. And then as it travels down, there's hardly any space for it. And that's because that jelly material from that disc herniation is now taking up the space in the spinal canal. And now the nerve signals cannot travel and you get pain that goes down your legs. And this is just another example of that. Next slide. How can we treat pain coming from a disc herniation compressing on nerves? So one approach is called an interlaminar epidural injection. This often involves steroid, and often we put a needle into the central space between the vertebrae, and we will inject steroid, some anesthetic, and maybe some normal saline there to spread the medicine around, and that will hopefully decrease the inflammation. I like to use this technique when someone has a central spinal stenosis and we're trying to get a general anti-inflammatory effect around that disc and around that spinal canal area, which is being compressed. Next slide. Caudal epidural is another approach that we can use. There's basically a door that enters the spinal canal through the tailbone, similarly to the epidural space above. And you certainly can enter through that door. Entering through this door allows you to put more volume in the spine. So if you want to do an injection and cover more than a few levels, you can actually use this approach and put a higher volume of medicine in. And it'll also do a good job of covering those nerves that are really closer to your tailbone. Next slide. Now this slide shows something which can also happen with a disc herniation, but can also happen with bony overgrowth. So instead of a disc herniation coming and compressing that central spinal canal area where the spinal cord runs and the spinal nerves run, it can actually kind of herniate to the side, and it can actually crush a nerve as it's coming out of the spine. So our spinal nerves, as they come out of the spine, control different parts of the body. So for the low back, for example, our highest lumbar 1 spinal nerve will control the movement and the feeling in your hips. And for an example, when we go lower to the L5 level, that might control the movement and the feeling in your feet. And then anything between L1 and L4 will be kind of going down the leg that way. So, L1 hips, L2 kind of thigh, L3, knee, L4 ankle, L5 feet. So just generally speaking. So if a disc herniation is compressing a nerve as it's coming out of a specific lumbar level, that nerve will produce pain in that level. So in this example, let's say this is the right L5 nerve. What's going to happen is the nerve will get crushed and you will have a pain which travels from your back down to your foot, okay? And you might also have a little bit of weakness in the foot, and you might have some numbness and tingling that goes there as well. Or if this nerve was sitting at the L2 level, for example, you might have a pain that travels from your back to your hips with some numbness and tingling and maybe a little bit of weakness. So basically, depending on where the insult is, will control what type of symptoms that you have. Next slide. And so what can we do for this? We can do what's called a transforaminal epidural steroid injection. So it's an epidural, like we talked about in the previous 2 slides, except instead of approaching the spine from the center angle or from the tailbone, we're going to be approaching the spine from the entrances at the side of the spine. So this is a very targeted injection. It really only covers the specific nerve that we're targeting, and it will provide not only potential relief to a disc herniation, but it will also provide our surgical colleague surgical colleagues diagnostic information. So if they're looking at your spine and it looks like you have multiple levels where nerves can potentially be compressed, but when they look at your symptoms, they're really thinking the L4 level is the one that's compressed, they might ask me to do an injection at the L4 level, maybe on the right side, because your symptoms are all right-sided. And once I do that, if that produces pain relief, then that will tell our surgical colleagues that, hey, look, the pain is coming from the L4 nerve on the right, and now they can do a surgery at that level. Next slide. So this here is your sacroiliac joint. So then now we're coming to sort of the lowest part of what we consider the spine. And so when your pelvis meets your tailbone, that's called a sacroiliac joint injection. And now people can have pain from this. Often people will describe it as a pain in the butt, because it literally is a pain in the butt. It can be on both sides or it can be on one side. It's common to have this pain when you have some sort of injury or insult which throws off your stability. So an unstable ligament around this joint will produce motion, which produces inflammation in these joints, and you'll have pain. Sometimes women, after giving birth to children, their pelvic canal has to open up to allow a child to pass through. And sometimes when it comes back together, it doesn't always come back together the way that it was before. And that can produce an imbalance in the sacroiliac joints and produce pain. Oftentimes when patients have had surgery and have had a big spinal fusion, their spine will be fused. And so the pressure will sometimes fall on the lowest part of the spine, which is your sacroiliac joint. And again, at that level, you could end up having pain because now your SI joints have more pressure. Next slide. So how do we treat this? We can do a sacroiliac joint injection in which we put steroid into the joint, and that can produce several months of pain relief. Next slide. We can do a sacroiliac joint radiofrequency ablation. And in this case, we take a needle, the end heats up like in the previous slide, and it will burn the nerves that signal the pain from the SI joint, so you don't feel that anymore. Next slide. And I guess the last little part of the spine will be your sacrococcygeal joint. And this is basically the small little joint that connects what's called your coccyx to your sacrum. And you can have pain there as well. That is really a point that is almost going towards the rectum and is reproducible with palpation. Next slide. And what you can do for that is an injection in that joint. Part of spinal pain can be myofascial pain. And this just means if the spine, in a case like scoliosis or some imbalance, can produce muscle pain. And if you have muscle pain, you can get pain. And if you have this muscle imbalance, you can get pain in the muscles. Next slide. And what you can do are injections called trigger point injections. I usually like to tell patients these are a medical form of acupuncture. And we basically try to get these knots in the muscles. We do what's called dry needling. We try to create a local inflammatory response so the body can sort of heal that muscle area itself. These can actually work really well in muscle pain. Next slide. This is just an example of a one-level fusion device, which is non-surgical, that interventional pain physicians can actually implant. I like to leave big fusions, honestly, to my surgical colleagues. But if a patient, for example, had a one-level problem, which wasn't too big, and they really wanted to avoid surgery, this is something we could potentially do. Next slide. A kyphoplasty, this is where someone gets a compression fracture. They have from a fall or from osteoporosis. We can actually do a procedure in which we put cement through a needle. We put cement in the fracture and we repair it by increasing the size of the fracture. Next slide. And this is just another example. Next slide. Spinal cord stimulation. This is where I was talking about that thing called neuromodulation. So in some cases, a person's not a surgical candidate. They don't want surgery. They've had surgery and the pain just isn't better. What we can do here is implant what's like a pacemaker for your back. Essentially, we put in these leads, they sit in the spinal column, and they pretty much will intercept the pain signal as it's going from the painful areas to your back to your brain, so you don't have to feel the pain anymore. This is a fully implantable system. There's a battery that is also implanted in your flank, and you can sometimes control whether this is on and off with your remote, and this can produce long-term pain relief. People always ask, do I have to change the battery? The answer is yes, but sometimes that doesn't necessarily happen for a decade. So this can be pretty effective. Next slide. This is just an FDA approved device, and there's multiple indications. Next slide. And now we want to say when to refer to a spine surgeon when the above conservative measures fail, if there's progressive neurological or motor deficits, meaning there's no time to see me because you're losing motion or function of your legs, if you have a suspicion for a tumor, mass, or an infection, or if you have severe intractable pain. And if any of those things happen, you want to see my colleague who's going to be talking to you next. And go ahead and take it away.
Dr. Brar, thank you very, very much for that interesting presentation. Now that we've kind of talked about the conservative idea and maybe we've gotten into some diagnostics, I think our next step is to take a look at what is going to be occurring with the surgical need. As my screen just died. And that's going to be with Dr. Jang. So Dr. Bowen Jang is a board-certified neurosurgeon and spine surgeon at Providence. He completed his education also at Stanford University with his neurosurgery residency and complex spine fellowship at the Johns Hopkins Hospital. With expertise in minimally invasive and robotic spine surgery, Dr. Jang is site director for California's only dedicated Excelsius GPS Robotic Spine Training Center. His clinical practice includes complex spine reconstruction, spinal tumors, neurotrauma, trigeminal neuralgia, Chiari malformation, and brain tumors. Dr. Jang has published numerous scientific articles and book chapters, primarily focused on robotic spine surgery. His dedication to providing exceptional neurosurgical care and his commitment to advance in the field make him a valued member of the medical community. When Dr. Jang is not working, enjoys interior design and taking care of his 10-month-old son, who I understand is actually present during the talk today. Dr. Jang?
Yeah, thanks, Tom. Welcome to the seminar. Thank you, Dr. Brar, for that wonderful introduction. I do apologize. You may hear some screaming in the background once in a while from my 8-month-old. I'm sorry, he's actually 11-month-old now, but he's just getting his dinner. So my part of the talk is I'm a surgeon. I'm a neurosurgeon, and a large portion of my practice is spine surgery. And my focus is on robotics and minimally invasive spine surgery. So I hope to talk to you about some of the newer frontiers and innovations that's going on in the field. In terms of the 3 pillars of treatment, Dr. Brar already touched upon this: medical physical therapy, interventional pain, which he has a repertoire for. But as a surgeon, my way of helping people is with my hands through surgery. Everybody that I've seen in clinic will tell me that they have had a family member or a friend who has had a bad experience with spine surgery, or who has had a bad outcome, or just was not happy with what happened to them. And yet, I still have a job, and I see success stories every single day in my own patients. So why is there a disconnect there? And why is there such fear and trepidation when it comes to spine surgery, when the majority of the surgeries that I do are outpatient? Patients either go home the same day or the next day. And when we talk about expectations and pain, and they're like, oh, I had a C-section, it wasn't even that big of a deal. I'm like, spine surgery, your incision is 1/20th of that incision for some minimally invasive procedures, and you're not gonna have any pain. So why the fear? And why the disconnect? And I think it comes down to this: surgery for the right diagnosis on the right patient is life-changing for the better. Take the opposite of that. Surgery on the wrong diagnosis on the wrong patient is life-changing for the worse. Back surgery, and I've had this question come up already in the chat box. Back surgery, in my mind and my philosophy, is this: back surgery is surgery on the back, actually to help with the legs, not necessarily to treat your back pain. And people get confused with that. because everybody comes to me and 99.9% of them have back pain. But when you delve deeper into that, it may actually be leg pain that they're experiencing. It may actually be leg weakness, foot drop, numbness, sciatica, all of which stems from nerve compression in the back, but it's not necessarily back pain. And over the last decades, surgeries have become less invasive and more modernized. My philosophy, it's always that less is more. So yes, for the right diagnosis, after we carefully select you, go through the ringer of diagnosis, maybe sending you for an injection for diagnostic and therapeutic purposes, getting the right imaging, maybe sending you for a nerve study to make sure we're operating on the correct level on the right nerve, on the right patient who's optimized. Maybe this is someone who's quit smoking, who is not morbidly obese, who has family support, who is optimistic. I can think all of those patients are going to have a very positive outcome, as opposed to someone who doesn't have the social construct and who is not willing to take those extra steps to optimize their health and who may have had a wrong diagnosis to begin with. In terms of surgery, there's two main buckets of surgery. There's decompression, taking pressure off the nerves, and arthrodesis, which is stabilization, or commonly known as the fusion procedure. Decompression, a common word that you're going to hear, is something called a laminectomy. This is a procedure that we as surgeons do. We take you to the operating room, we make a small cut in your back, and we use a high-speed drill to actually drill away a little bit of the bone to open up the nerve channel to take the pressure off the nerves. As you can see from this diagram, what we want to do is expose that yellow sac in the middle, which is your dura and thecal sac, all medical terms to say that this is your garden hose in your back, which has your nerves and spinal fluid in it. This is a procedure that we use to treat spinal stenosis. Stenosis meaning narrowing or pinching of the nerve sac, typically because of age-related degeneration and arthritis. Oftentimes, you'll hear commonly used terms: arthritis, bone spurs, bulging disc, herniated disc tears. They're all catchphrases for just saying that you have age-related degeneration in the back. And every person does have some degree of that, because every person, as we age, we'll get wrinkles, we may get white hair, we may get more and more fatigued, and we will all have some degree of degeneration as we age. And the question really isn't to focus on the fact that you have a bulging disc or you have spinal stenosis. Really, it is to talk to a doctor and make that relationship and figure out the severity. Is it mild, moderate, severe? And also, is it actually causing your symptoms? There are a lot of patients who have severe image findings, but have mild symptoms or no symptoms at all. And there are a lot of people who have very mild radiographic findings who have severe symptoms. So that disconnect sometimes, that's the art of medicine. And that's why you have to have a physician kind of look over your case as opposed to just go on Google. This laminectomy is the workhorse of what we do as back surgeons. And there's so many ways to do this surgery. Traditionally, we would open up the back, make a large incision. And many of you have had this, probably seen a family member has had it. But now we can do this minimally invasively through the use of little tubes, which dilate through the muscles with Band-Aid size incisions. And sometimes we can even do this endoscopically, meaning put a camera in through a small port in your back and target the decompression, take the pressure off the nerves in a very small manner. There's pros and cons of both approaches. And as a minimally invasive trained surgeon, I actually still do open. And the reason is because, and again, this is where that nuanced dialogue needs to happen on a patient-to-patient specific basis with your spine surgeon. Sometimes if your disease is so widespread, we're talking about 5, 6, 7 levels of stenosis, and it is so extraordinarily severe, minimally invasive may not be the best option for you. If it's just one single level and you're a professional athlete and you want to get back to playing baseball in 4 weeks, then maybe the endoscopic fashion might be the best thing for you. The less invasive you do, the less we're able to fully decompress and thoroughly decompress your disease at that level. So there is always the caveat that I always tell my patients, if we're going to do the smaller surgery, you have to mentally prepare for the fact that up to a small percentage of people may need to come back and get converted to the open surgery so that we can take more pressure off the nerves. Beyond decompression, we can put things in people. These are smart implants, and these are implants that can either replace something that's degenerated, or stabilize something that's degenerated to the point of instability that it cannot withstand the pressure of your daily life. One technology that I'm truly passionate about is something called an artificial disc replacement. And this is something that I do a tremendous amount of, especially in the cervical spine. Typically, this is done for cervical stenosis or degenerating discs with nerve root compression, either stenosis, radiculopathy, or myelopathy in the neck. And over the last 10 years, there's been immense study on the use of this device over traditional fusion techniques, where we would go into the neck, put in cadaver bone, plates, screws. And in fact, recent data have suggested that artificial disc replacement is actually superior in terms of long-term outcomes, in terms of patient satisfaction, adjacent segment disease, meaning levels above and below your surgery breaking down, and overall, just long-term pain relief. Most of these patients that get this surgery from me either go home the same day or within 23 hours with a short overnight stay. They have minimal pain through one of the natural creases of their neck. And the most important thing about this is that this is motion sparing and motion preservation. You can see this person, 3 months follow-up, with those 2 little white implants there that fits in perfectly to this space. As they're bending forward and bending backwards, they have full range of motion. There's no migration of the implants, and these implants then hold the structural vertebrae together and offers them the support, but still allows them to be active in their life. Oftentimes, these are patients that are a little bit younger who do not have significant disease in their joints in the back. So again, a careful conversation needs to be had with you and your surgeon. Today, I would like to say that enabling technologies in spine surgery really help us do the spine surgeries better. We get to work smarter, safer, with enhanced accuracy. This is like GPS on your cell phone with either Apple Maps or Google Maps, or a smart timer on your oven that tells you when your food is ready and it shuts the oven off automatically. For us in spine surgery, this is vitally important, because spine surgery, and I think one of the reasons why people fear it, is they say, will I become paralyzed in spine surgery? I've heard of so-and-so, or my wife or so-and-so end up in a wheelchair. And it's a never event that should never happen. But when we're working with the human central nervous system, when we're working with the brain and spine, certain things can happen that are high risk and do lead to complications and consequences. So this is an example of a malpositioned spinal cord screw, a screw that went through the spinal cord. It's supposed to go through the pedicle, which is a sliver of the bone, but instead it went through the middle of her spine and caused paralysis. Even in the most gifted hands, surgeons who have performed tens of thousands of pedicle screw placement, we're all still human. Sometimes this can still happen in the most gifted hands. And that's why enabling technology, I'm a true believer of it, can help us improve that accuracy so that we take something that could be a 1 in 10,000 to a 1 in a million. So how can we do it better today in terms of improving spine surgery? Well, we want to capture patients that are seeking less invasive surgery. We want to reduce radiation, because during surgery, believe it or not, there's a lot of x-rays being shot that's zapping you and me. And this may be a one-time thing for you, but I'm getting zapped 3-4 times a day, every single day, right? We want to reduce operating room time. We want to decrease the estimated blood loss for your surgery, reduce your length of stay in the hospital. Overall, just make sure that you're discharged out to home to be with your loved ones, make it more cost-effective for you, and just make it a better experience. So my personal background, coming from Stanford and Johns Hopkins, I've always been very obsessed with latest technology. And when I was at Johns Hopkins, I was fortunate to meet this man, Dr. Nick Theodore. He actually performed the first real-time image-guided spine surgery using a robot in the country back in 2017. He invented the robot that we currently use. At the time, we were the first institution to use this robot in all of the whole world, actually. And I was able to train with him and bring that technology to Providence from the East Coast, establishing one of the only dedicated spine robotic centers in California. And now with this same technology, there's over 400 hospitals worldwide that uses this. So this is something that's very special to Providence, not only because we offer robotics, but because we offer robotics from the leaders that actually created the technology, the people that trained with those leaders and continue to work with those companies to do process enhancements to improve the robot for the future. This is an example of how that works in surgery. I have a foot pedal. And the robot arm then just goes into a pre-planned trajectory that I have already planned using your CT scan that's obtained after we meet each other in clinic. I then go to the robot console on the iPad. I'm actually able to plan your screws exactly the way I want it. And then once we get to surgery and I know I want to put those screws in, I use the robot, I navigate the arm to the appropriate levels. And then here I am just percutaneously, meaning through the skin without dissecting the muscle off, putting the screws in without any issues. Very safely and accurately doing that without much violation of the tissue. Here's an example. This is a very pleasant lady. Her name is Shirley. She has given us permission to use her imaging. She was 84 when I met her. She had been a ballroom dancer internationally competing until she was 80. And unfortunately, over the next few years, as she got to 84, she couldn't walk anymore. This is a lady that was walking 20,000 steps a day. And all of a sudden, she wasn't walking anymore. She wasn't dancing. She was almost bedbound in a wheelchair. And we found out that she had severe spinal stenosis with slip vertebrae. And she really, really wanted a minimally invasive approach. She had been offered traditional spine surgery with rods and screws with 2 other surgeons, and she was just deathly afraid of it. So finally, she agreed to surgery with us, and here's me planning her surgery on the robot. And here's me actually doing her surgery. Not a drop of blood. You don't see a big open back. You don't see rods and screws. You don't see any of that. And all we're doing right now using a robot, I'm already putting the screws in. And here we are. We have already put the screws in, and I'm using navigation and GPS to tell me where to use the microscope to under 10 times magnification, take the pressure off her nerves. And here she is, multiple years later, dancing with me in the clinic, right? So this is the joy that I get from being able to take a patient who is almost bedbound, who was very active, and at 84 still looked like she was in her 60s, and bring her back to this at the age of 87, dancing in my clinic, and she's back to walking 10,000 steps a day. So this is the power of spine surgery. And again, this is a very common outcome in the spine surgery clinic. When you do the right surgery on the right patient in the right way, people have positive outcomes, right? And here's another robot that's recently been introduced, and we are actually at Providence. This is a robot that's been used in France and Geneva. And as part of Providence, we're about to become the first center in all of North America to bring this robotic technology to one of our hospitals, one of the ministries in Orange County. And again, it's the focus on technology and innovation that brought me to Providence. And we're continuing that now with the next generation robot, kind of like your iPhone 1. Now this is iPhone 2. Again, GPS for surgery is so vitally important. As a spine surgeon, I rely on GPS, but even more vitally important, I'm also a brain surgeon. I do brain tumors, critical brain bleeds. I help people with facial pain. And if we don't have navigation and GPS, it makes it very hard for us to find out where the problem is in the back and target it precisely. So this is such an important tool for us to use. And we've written numerous articles on this, and these were all written by me not too many years ago, preeminent journals in the field, talking about how using a robot and using navigation and comparing that with the traditional way of using freehand in short segment fusions, and also assessing and validating that technology with 3-dimensional assessments, computer AI generated software. It's actually validating our beliefs that using robotics and GPS systems for navigation is enhancing and improving our surgical outcomes. Finally, I'll end the talk with other techniques and technologies that's advancing in the fusion field. Now, a fusion, again, dreaded word. A lot of patients, when I tell them, hey, you're going to get a fusion, they get very scared because they're like, I don't want rods and screws put in my back. I don't want cadaver bone. Well, a fusion is not the same as it used to be, right? Here's an example of a fusion that I do, which is a minimally invasive fusion coming in from the side. So this is fitting your back, not from the back, but from the side. And here's a video of how that works. So this is a procedure called an XLIF, or extreme lateral interbody fusion. Lateral meaning coming from the side, interbody meaning going in through the disc and fusing that area. So what we do is we come in from the side of the spine. We actually put in this small minimally invasive retractor and the shim, and we target that disc. And this is perfect for patients with scoliosis. So if you have a coronal deformity, your back is crooked, like this back right here, and we want to find a way to correct it, I may actually at this point suggest, hey, we're going to have to do a combination of a minimally invasive procedure where I come in from the side and fuse the disc together and use that methodology to straighten out your spine, just like this, okay? And that might be done, I might have to do that at 2 levels, I may have to do that at 3 levels. That'll be day 1. We finish those surgeries, I let you be admitted to the hospital, I let you rest up, have dinner. Then the next day, we actually then do a traditional bigger surgery from the back to fully put rods and screws in and correct it. That way, we're saving you from more complications to having surgery from the back and a bigger operation from the back to put in these cages. Another procedure that I'm well known for, and it's this is another thing that we use the robot for, is something called a T-lift, transforaminal lumbar interbody fusion. Again, inner body between the disc, between the vertebrae, so you're affecting the disc, fusing the disc together, fusion, putting rods and screws in. But instead of the traditional one here on the left, where you have to essentially fillet someone's back open, almost like deboning a chicken wing, right? You got to see the bone. I don't need to do that anymore. I keep all your tissues intact. I'm not opening up the back in a big fashion. I'm not ripping the muscle off the spine. I'm not tearing the ligaments, but instead I just dock a tube retractor that distracts and retracts. So it's dilating through the muscle as opposed to cutting the muscle. And I'm able to do this whole procedure, put the rods and screws in and cage in under 2 hours and have you go home later the same day or the next day. Finally, this is another operation that we do in conjunction with our vascular surgeons. This is otherwise known as the Tiger Woods operation. You go in from the front of the belly in order to do a disc and take out the disc and replace it. And this could be done for a disc replacement, mostly at the L5-S1 junction, or it could be a fusion where we put in a cadaver cage and with titanium. So what we do is we very carefully move away some of the abdominal contents and vasculature to get access to the spine, especially at L5-S1. If there is a collapsed disc or nerve impingement, I then remove the disc, completely shave the disc away, prepare the end plates, and then I can then put a cage in to almost like a little car jack to elevate the space and then affect decompressed nerves. So I'll end on that note. I do think the future is now for spine surgery. Again, a lot of personal questions in the Q&A. We can't answer those for you, but I think you should see your primary care doctor, get the imaging done, and then be referred to a spine surgeon within Providence. So any of us can discuss with you the different options. I think the future for spine surgery goes beyond what we just discussed. What about the possibility of disc rejuvenation? A lot of people come to my clinic asking about stem cells. That's not mature just yet, but maybe in the future, right? I'm personally working on something that's related to incisionless spine surgery. What if we can do spine surgery but not have to make that big cut at all? What is surgery anyway? Isn't surgery just affecting and manipulating tissue inside the body? And for years and decades and centuries, we've been doing that by cracking people's heads open and putting our hands in their bodies in a maximally invasive way. Why does it have to be like that? Why can't it be like Star Trek in the future? You just sit there, listen to your iPad, or put in your headphones, watch a TV show, and we just did spine surgery on you. Why not? Augmented reality, remote controlled spine surgery, and the next iteration of robotics, all that is going to be in the horizon. And hopefully we'll see you in 5-10 years with a similar lecture on those topics. So thank you again for tonight. Really nice to meet all of you and happy to answer any questions for you.
Thank you very much, Dr. Jang. That was amazing. And also, again, thank you, Dr. Brar. Nice to know we have well represented from the Pac-12 too, which makes me very happy. Before we begin our Q&A, we do have a few questions for you. Thank you very much for attending. If you could please answer the poll that will soon appear on your screen and give us your honest feedback, we would greatly appreciate it. And now we're going to go ahead and get started with our Q&A. Feel free to continue to ask questions. We're not going to be able to get to all of them this evening. We'll be wrapping up roughly around 6:29 on that last question. But write those questions in the Q&A box. And if it's something that we feel that we can comfortably answer, we will definitely try to make sure that we can get those answers at another time to all of you. Again, let's go ahead and get to the questions. And, you know, there were a couple of questions that were kind of offered prior to us even starting the talk today. And I thought maybe we might start with a few of those first. And Dr. Jang, you know, you spoke a lot about the procedures, you know, and this might be a multi question, but will these procedures permanently cure my pain? Does the procedure actually hurt? And what do you see as a recovery?
Yeah, it's a loaded question. Sometimes I tell the patients that unfortunately there is no guarantees and there's no 100% perfection with every single expectation. I tell them that there's two versions of success. My definition of success is, am I able to successfully accomplish what I set out to accomplish? And that's a pretty high rate. I go in surgery, I do my surgery, and I do as good of a job as I can. Does that always translate to pain relief, 100% improvement? And sometimes not always, but the majority of patients will have an improvement. And it does take rehabilitation too. It's not always immediate. It depends on how badly you were suffering before you went in for surgery. If you have had a chronic issue, it's going to take you a little bit longer to recover. So I always say physical therapy after surgery is very important, and to just give it time and patience and let the body heal itself.
Thank you. And Dr. Brar, I'd love to tee that one up for you as well. Between a number of the procedures that you offer, what should patients expect? And
So, our procedures are, they're not physical fixes. So the procedures can provide meaningful relief for a period of time. Typically for steroid injections, we can get people 3 to 6 months, at which point they can be repeated. For some of our ablations, sometimes you might get 6 months, 2 years. And for an implantable device, sometimes that can be long-term. We're not actually manipulating the spine or the tissues like Dr. Jiang does. We're actually trying to manipulate the way that the body communicates and the nerve signals communicate with the brain so that you don't feel a pain anymore. And sometimes it can be temporary, sometimes it can be, longer term.
no, I appreciate that. Thank you very much. You brought up something, there was a question in the chat as well, was in regards to steroid injections. Is there actually a limit that we should probably think about for patients receiving injections?
Yeah, steroid injections. So I want to give a big caveat. Not all of the procedures that I talked about have steroid injections. It's only a fraction of them. A lot of the procedures that we do not involve steroid. But yes, steroids can have adverse effects. And like anything, if you have too much of something, it can be bad. Steroids can have many potential side effects, and the list is innumerable. And resources can definitely be found online with your endocrinologist, primary care provider, or one of us. But you don't want to have too many steroid injections in a given period of time because you can have an adverse effect.
No, thank you for that. And I just want to throw a quick reminder before we move on to our next question. That in the case where sounds like you probably should talk with a physician first. I know a few of the answers came back that maybe talking with a physician. If you don't have one and you need a physician, we do have a patient engagement center that will be able to assist you in getting to a physician in order to have your back or your spine related issue looked at. You can reach them at 1-855-415-8191. Also, you can visit us over at providence.org and go into Find a Doctor, and that will also assist you by finding a physician that's going to be close to you that will help at least get your journey started and get you on the right track. There was a great question here, Dr. Jang, and that just moved on me. Just briefly, do you see disc replacements beginning to become a little bit more commonplace, where it used to be just standard they were going to go to a fusion?
Yeah, absolutely. Especially for cervical disc replacements. It's interesting where I train on the East Coast at Hopkins, obviously top-notch academic institution. Within the 7 years I was there, I did less than 5 artificial disc replacements. I did 5 just in last week alone here. It's on the West Coast, there's definitely a little bit more progressive treatments. But that said, there's emerging data. There's actually literature, scientific proof that was recently came out in a published journal that suggests that artificial disc replacement in the cervical spine, again, when done on the right patient with the right disc for the right condition, actually is actually better in terms of long-term outcomes compared to fusion. So I used to think fusion first and the artificial disc would be these sort of unicorn patients, the rare patients. Now every patient I evaluate are they a candidate for artificial disc? And if not, do I really have to fuse them? And if I have to fuse them, then I guess I have to fuse them, then I have to have a conversation about that. And the lumbar spine is a little bit more challenging because there's a lot more weight bearing and loading on the lumbar spine, especially the lumbosacral junction. And a lot of people, the reason why they need surgery is more so because they have a slit vertebrae or there's instability, there's fractures. The data for that is not quite completely there yet, but early data also do suggest that there may be some benefit to that. So there could be, that's currently under investigation. I currently don't do them, but as the data continues to emerge, I'll be one of the first to jump on that as well.
Thank you for that. And, Dr. Brar, I'd love to finish our questions up with this because this one showed up quite an awful lot of times in various forms. What is your recommendation as it would be in regards to therapy, going to physical therapy, chiropractic, acupuncture? Are they the effective modalities? And do you find that they can be appropriate for some versus others?
Absolutely. As I was kind of saying at the beginning of my talk, you only really need to see us, me or Dr. Jiang, when some of those modalities fail. I think the majority of patients actually don't even make it through our doors because they do find effective treatment from chiropractic, acupuncture, and physical therapy. And when we look at studies, physical therapy actually is shown to have the best evidence of treating people's back pain. So, I probably wouldn't even, if it were my own back, I probably wouldn't even come in for an injection or a surgical procedure unless I've exhausted some of those conservative options first. And the majority of people will get better from those options before they see.
Sure, appreciate that.
Yeah.
Perfect. Well, again, I thank you, Dr. Jang. Thank you, Dr. Brar. And I want to set special thanks to everybody who attended this evening, attending this lecture for your excellent question. Yeah, your questions were fantastic. Hopefully we've been able to get to a lot of them. The questions, we still have those even once the lecture is done, and we will try to continue to answer as we can. A big thanks to Dr. Brar and Dr. Jang, to Providence for putting this together as well. We will be sending a recording of the presentation. There was a question regarding that to all of the attendees, and it will also be posted on our Facebook pages, also our YouTube channel, which you'll be able to access by typing Providence in the search bar when you're on YouTube. As mentioned earlier, there are 17 Providence hospitals throughout California, and as shown on this map, here we go. That's the one. You can see this both here, and then you can also find it at providence.org. We look forward to being able to have the opportunity to care for you and your loved ones. And remember, if you do need a physician, as it's here on the screen now, please don't hesitate to contact our patient engagement center at 1-855-415-8191, or visit us at providence.org and just click on Find the Doctor tab in the navigation bar. Again, thank you very much for being able to attend today, and I hope you have a very pleasant evening.